Hi, everyone, and welcome to our session on pediatric point-of-care ultrasound. I'm Dr. Anna Aspler, our POCUS director at North York General Hospital, and I'm delighted to be joined by Dr. Michelle Lee, POCUS faculty and expert from SickKids. We have no conflict of interest to declare. So if you saw Dr. Michelle Lee doing POCUS at SickKids, these are all of the different things you may see her scanning. Obviously, we can't cover all of this today, so we've chosen two core applications, lung and soft tissue, and two of the can't miss diagnoses in pediatrics. We'll cover the basic technique, some interesting clips, pitfalls and pearls, but we won't be able to cover anatomy, all of the indications and contraindications, or the evidence base. So soft tissue is one of my favorite applications to do at North York General Hospital. If you see a kid of any age with red hot, swollen skin, the question may be, is this a cellulitis or an abscess? And if you do feel a lump, you would want to make sure there's not a foreign body there, and you obviously wouldn't want to go and IND a lymph node. The technique is very easy, one of the most simple types of ultrasound to perform. You just want to make sure that you do it in two planes. So what I mean by that is doing a full transverse and longitudinal view of the entire area of redness and swelling. I would apply Doppler if I saw anything that looked like an abscess or a vascular structure, just to be sure that we're not putting a needle into a vessel. And then finally, I would measure if I saw a cyst or a structure, how big the structure is in two planes, and then also how deep it is from the skin surface. So on the left, you see normal soft tissue, which is more of a linear architecture. On the right, we see the classic appearance of cellulitis, which we call cobblestoning, where there's fluid interspersed with the adipose tissue all above the fascial plane. This is an example of what an abscess would look like. Abscesses come in all shapes and sizes. So sometimes they can just look like a simple hypoechoic cyst. And as they progress, they can look more heterogeneous like this one. If we look at the markings on the side, we can see it's approximately 2 by 2 centimeters. So I would say this is one that's amenable to drainage. Before draining it, I'd apply the color Doppler box. And I certainly don't see anything that suggests that there's a major vessel in the way of doing this IND. So some pitfalls. You obviously wouldn't want to IND a lymph node. What do lymph nodes look like? They're more elliptical in shape. You'll see this central hilar structure, and then you may see some flow centrally around the hilum. This is obviously way beyond the scope of point-of-care ultrasound, but I do want to say, if you see anything worrisome like not well-defined margins, absence of the hilar structure in a lymph node, or some central necrosis, or it's greater than a centimeter, you may want to refer for formal imaging or to the pediatrician for follow-up. Another pitfall can be failure to recognize a foreign body. So this was a case of an autistic boy with a recurrent buttock abscess that failed multiple courses of antibiotics. Finally, a POCUS was done showing this linear foreign body that was actually a pencil. Interestingly, there are different signatures on ultrasound for different types of foreign bodies. So with metal, you can see some vertical artifacts like comet tails. With glass, you can sometimes see horizontal A-line-like artifacts. And with wood, you basically just see an acoustic shadow without those other artifacts. A pearl to consider, especially in very superficial structures, is using a water bath or saline bag, or even just a bag with glove, in order to enhance your acoustic window. And you may even find that the pediatric patients find this more entertaining, and it makes it a little more comfortable for them. A third pitfall would be if you don't image the entirety of the abscess, you may miss that it's extending a little bit deeper. So in this case, it was the buttock abscess again, but there was actually a fistula. You can see it starting to extend down there. So in this case, general surgery was consulted, and then the child had a CT. And this would not be one that's appropriate for drainage in the ED. Finally, in the periumbilical or inguinal area, you may be surprised to find that there's actually a hernia there, and it's not cellulitis or an abscess. And this is what a typical inguinal hernia would look like. You obviously wouldn't want to go and IND that. My next application that I do use in my practice is to rule out testicular torsion. So the main question is there a complete lack of flow to the testicle, because if I see a complete lack of flow, I'm going to feel confident to call urology directly with my point of care scan, and I'm not going to wait for the formal scan because the time is of the essence. So the technique, we use a high frequency linear probe, and the most important thing is getting the patient really comfortable. So I will give them sometimes morphine even before I do the scan if I see they're really having pain out of proportion, because it's going to optimize getting the best view. I get them in a frog-leg position, so that's with like the knees open, and then I get a scrotal support underneath the scrotal sac so they're more comfortable, and then one for their privacy to drape on top. And then I use the most amount of gel possible so that it's as comfortable as possible. I generally go straight for what I call, the money shot of looking at both testicles at once. And in most kids, it's very easy to see both testicles in one view. And then I'll apply the color Doppler and titrate the gain to the unaffected testicle. And I'll explain a little bit more in upcoming slides. Now, the gold standard I put in gray here is you would examine each testicle in a full transverse and longitudinal plane, just like we talked with our soft tissue scans. But sometimes you can make the diagnosis without even doing that entire transverse and longitudinal view of the testicle. So this is the bilateral testicles view. My approach is to look from outer to inner. So I look at the skin. Is there any sign of cellulitis? I look around the testicle. Is there any fluid around the testicle? Then I look at the sizes. Is one bigger than the other? And then I look at the inner echo texture. And generally, you are expecting they're going to look similar. And if they're starting to look a little more heterogeneous, then obviously you're concerned about pathology. So then I apply my color Doppler box. Generally speaking, you want to drag it to include both of the testicles. And then I would turn down the color gain completely off and just gradually turn it up until I'm just starting to see flow on the unaffected side. So let's see some clips of what this looks like. So here we see a testicular torsion on the left. So the testicle is enlarged. We see some fluid there, and we certainly don't see any flow on this affected testicle. This is another example I wanted to include because there's a bit of what I call a motion artifact. So you do want to try to hold the probe as still as possible, because otherwise you're going to see some speckling with movement of the probe. But even despite seeing this on the affected testicle, it's clear there's no flow to this testicle. Here we see obvious blood flow with the artifact, and here we're only seeing artifact, no flow. On this last clip I have for you, this is a later torsion where the echo texture of the testicle is actually starting to change because of the lack of blood flow. So in this case, yeah, I definitely wouldn't hesitate to call urology right away. This patient needs to go to the OR. So the pitfalls, titrating the gain. I know I've mentioned this a couple of times, but I just wanted to show you in an unaffected testicle what I would do. So I would turn down the color gain, like I said, down to 0, and you can see it looks like there's no flow when it's down to 0. As we're turning it up, you're going to start to see flow, and then it gets a bit overgained. So I would turn it back down until I'm just seeing the most minimal amount of flow that's going to give you the most accurate scan. Another pitfall is torsion and detorsion. So if you see a patient and they're in severe pain and then they're in no pain, and then you see a lot of flow to the testicle, very suspicious for torsion detorsion. Orchitis can look exactly like this sonographically, but it will be differentiated by the clinical picture, where with orchitis, they're going to have ongoing pain. And then finally, torsion is on a spectrum. So complete torsion is 360-degree twisting of the testicle, but you can get partial torsion where you're seeing only decreased flow and not complete absence. In this case, if the clinical story was still suspicious, I again would still call urology, but you may have time to get that formal scan where radiology would do something called a resistive index with the spectral Doppler. And I can talk about that if there's time with the questions. I'm going to pass it along to Michelle Lee, who's going to cover lung and intussusception. Thank you.
So the next topic is lung POCUS, which I'm very excited to discuss with you, since it's arguably one of the most useful applications in our day-to-day practice in the pediatric emergency department. So the most common scenario where this is helpful is when you're seeing, let's say, a healthy toddler who's coming in with coughing and rhinorrhea for a few days, febrile for 3 to 4 days. And when you're trying to auscultate her lungs, she's screaming her head off. And your question at the bedside is really, is this just a viral illness or is there a true pneumonia? And instead of ordering blanket x-rays on every single one of these kids and exposing them to radiation, POCUS can be very helpful in helping you actually take a look inside the lung to see what's going on. Maybe it's a well-appearing child where a normal POCUS could corroborate your low suspicion, or maybe it's one of those borderline cases and POCUS helps you identify a true pneumonia and also tell you whether it's complicated with an empyema or effusion. So a few key things to highlight when it comes to the technique of doing a pediatric lung scan. First, use a linear probe. This gives you a really crisp view and works well in children because they have very thin chest walls. Second, you really want to examine all 6 lung zones. So bilateral anterior, axillary, and posterior views. You really want to position them well by sitting them up or having their parents hold them so that you can get a good look at the back, since the posterior basis is a very common spot for pneumonias to be found. And you want to examine all 6 lung zones from apex all the way down to the diaphragm, scanning in longitudinal view for screening. But as soon as there's any small signs of abnormality, we should really be further interrogating that area by turning the probe transverse and also sliding it from side to side. Here's an example of a normal lung view. You can see the rib here with the rib shadow. Just underneath the intercostal muscle here, you have the pleura, and there's lung cladding as the patient's breathing in and out. Below the pleura, you're not actually seeing the lung itself, but what you do have are these horizontal A lines, which are reverberation artifacts, indicating that the lung tissue below the pleural surface is normal and aerating well. In contrast, here are some POCUS findings when you do have a pneumonia. So when the lung tissue is diseased, you can actually visualize the lung appearing hepatized, meaning resembling the liver in echogenicity. You can have some lung shredding, maybe some confluent B lines, and you may see some air or fluid bronchograms. The absolute measurement, it's not so important, but the area of diseased lung is usually larger than a centimeter deep for true pneumonias. Now let's go over some examples of the range of possible findings. So in this scenario, you have A-line artifacts going all the way down with no identifiable consolidation. You do see some comet tails here and there, but they're not true B lines since they don't beam all the way down. This would be considered a normal POCUS. In scenario 2, you may see something like this, where the pleural line is slightly broken and you have this small darkened subpleural area indicating a small loss of aeration right there. Something like this should just trigger you to interrogate the area so that you're capturing the maximal depth. But if this is the full extent of what you see, it's likely something that won't show up on X-ray anyway and can be consistent with a viral illness in the right context. In this scenario, you have some B lines in the beginning, which are non-specific if you see them in isolation. But it should really trigger you to look around since it could be the border or the start of a consolidation. Like in this case, in the second half of the clip, the consolidation appears as this hepatized area. So here's another example of pathology. On the left side of the screen here, you have some confluent B lines that lead you to the true pathology, which is a large consolidation with hepatization, some lung shredding, and also some bronchograms within. It's definitely a large consolidation extending beyond the screen, measuring greater than 3 centimeters. POCUS can also help you identify complicated pneumonias. So in this case, you can see the hypoechoic pleural effusion with some septations within it. And also wanted to point out the diaphragm here that you can see at the bottom of the screen. And it's a very important anatomical structure to look for, this double-lined diaphragm, since it distinguishes what's in the pleural space versus in the intraperitoneal space for you. Now let's go over some pitfalls to pay attention to when you're doing lung scans. So first, you need to be aware that the thymus can sometimes be confused with a pneumonia. And to differentiate between the two, think about location, age, and texture. The thymus is usually seen anteriorly only, and it's usually in younger patients. The younger they are, the more prominent their thymus is going to look. In terms of texture, thymus is much more homogeneous with a very clean border and often described to have this starry sky appearance. Another common pitfall when you're looking in the left anterior and axillary area is the stomach. So if someone is looking at this clip very quickly, they may mistaken the area here to be a pneumonia, given the loss of A-lines and maybe some irregular appearance. But if you develop the habit of looking for that interface between the single-lined pleura and the double-lined diaphragm, it's easy to identify that this area is just stomach with content. Another potential pitfall to note is a small percentage of pneumonias that are very central They may be very small, and if they don't abut the chest wall, they may not show up on POCUS. So you always have to clinically correlate. But try not to let this discourage you from doing this scan completely, because in the children for which you have very low pretest probability anyway, a normal POCUS could still be helpful in corroborating your low suspicion and help avoid unnecessary x-rays. So the last pitfall is just a note about POCUS use in asthma. So though we're all POCUS enthusiasts, it cannot completely replace a stethoscope just yet. We don't tend to POCUS kids who are wheezing and have suspected asthma exacerbation because they can have atelectasis that's sometimes hard to distinguish from pneumonias. So we would treat these kids with puffers to first open them up, and only if they don't respond, then you consider using POCUS as a tool you could use to look for alternative diagnosis for the child's respiratory distress. The last application we would like to quickly cover is intussusception. So every year we have several token cases of children who were triaged as CTAS 5 for constipation, and they end up having a POCUS diagnosis of intussusception. Now we all know that constipation is a clinical diagnosis, and we definitely don't need to POCUS every constipated kid, but the scenarios where it may be helpful are the toddlers who are coming in with abdominal pain, and then on your further history have a few soft red flags, like maybe they have episodic leg pulling, or the crying is more intense than you would expect. And depending on where you work, radiology may not always be readily available. So in those cases, POCUS can help you risk stratify and figure out next steps. Let's start by discussing the technique. So in small children, using a linear probe can give you a really nice crisp view of the abdomen. You would start in the right lower quadrant and look for your typical anatomical landmarks. So in this case, it would be your psoas muscle and the adjacent iliac vessels. You want to start in the right lower quadrant and go up the ascending colon into the right upper quadrant, which is the most classic location. And if you don't see it there, you need to keep looking in the entire abdomen by following the trajectory of the large bowel and then zigzagging within this frame to interrogate the small bowel. Now, as you guys know, intussusception is where there's a loop of bowel that's telescoped within another loop, usually the ileum stuck within the cecum. This is what it would look like intraoperatively, and this appearance is exactly what you're looking for on ultrasound. Generally, it's very hard to miss the very obvious intussusceptions on POCUS. They'll often pop into view as a large target or donut sign, appearing as concentric rings of different echogenicities. The classic ileocolic intussusceptions are usually large, measuring greater than 2.5 to 3 centimeters in diameter from outer rim to outer rim. Sometimes intussusception may not have the classic target appearance though. For example, if you're catching the intussusception in a longitudinal view, it may resemble more of a sandwich rather than a target. So if you have a suspicious area, just remember to change the orientation of your probe and to get a better look. Or sometimes it can look like the kidney. So if you're not sure, just always look for the actual kidney to confirm where you are anatomically. Another pitfall to highlight are the possible mimics. So example on screen left here has a loop of bowel that looks unusual, but this is not a target sign. And rather, this is a loop of bowel that is thickened in a patient with head-out shoreline purpura coming in with abdominal pain and has some bowel edema. On screen right here, there's yet another area of bowel that looks unusual. Again, this is not target sign, and in this case, it's a perforated appendicitis with abscess formation. Sometimes you can have intussusception that is small bowel looped into small bowel. These tend to be really small, so usually measuring less than 2 centimeters and can be self-resolving, but it can be sometimes hard to distinguish from ileocolic intussusceptions. And sometimes intussusception can be caused by pathological lead points. In this case, the size of the intussusception is small, but there is actually a round structure with shadowing inside its intussusception, which was actually a GJ tube that was causing this particular intussusception. The bottom line is that if you see anything that resembles intussusception, whether it's your classic ileocolic target sign or a small bowel, you should always clinically correlate and have a very low threshold to confirm with comprehensive ultrasound by radiology. But at least if you're able to identify the very obvious classic intussusceptions, it can really expedite the bedside diagnosis and help the patient get definitive treatment in a more timely fashion. So now let's summarize our take-home points for the 4 applications we covered. First, soft tissue POCUS can help you figure out if the lump and bump in this child is caused by cellulitis versus a drainable abscess. It can also help you identify foreign bodies and other structures that can potentially cause swelling, like infected lymph nodes or hernias. Testicular POCUS can be helpful in expediting a diagnosis of testicular torsion. Some technical tips would be to provide adequate scrotal support, analgesia, and using a lot of gel. But be mindful of pitfalls like torsion detorsion and partial torsion. Lung POCUS is frequently used in our pediatric ED to help identify pneumonias and its complications. Some technical tips would include to always scan from apex all the way down to diaphragm, and don't forget to get good posterior views. But beware of pitfalls like the thymus, stomach, and the use in asthmatics. Lastly, POCUS can help you identify obvious intussusceptions. Remember that you are looking for the target sign that's classically in the right upper quadrant, but you should really be scanning the entire abdomen. And beware of the variety of appearances and the possible mimics. And that's all we have time for today, but hopefully we have piqued your interest enough to dive deeper on your own. Thank you for your time.